All right, everyone. Welcome to this week's installment of AMSSM's National Fellow Online Lecture Series. My name is Matt Wise. I'm one of the current sports medicine fellows at the University of Utah. I have a background in family medicine, and I'm the outgoing fellow liaison to the Education Committee. Before we get into our topic for tonight, I want to remind everyone of next week's lecture on lower extremity peripheral neuropathies. Our speaker will be Dr. Ho, and our moderator is Dr. Creech. Same time as always, Wednesday evenings. Moving on to tonight, I'm very excited to welcome Dr. Lauren Borowski to speak to us on rheumatology in sports medicine. Dr. Borowski graduated from Drexel University College of Medicine and then completed her family medicine residency at Wake Forest University prior to doing her sports medicine fellowship at the University of Utah. She is now an assistant professor at New York University in the Department of Orthopedic Surgery, where she is also associate program director for the primary care sports medicine fellowship there. She functions as medical director for athletics at Convent of the Sacred Heart, Baroque College, and Yeshiva University, and is also head team physician for U.S. ski jumping. Before we get started, we also like to mention the goals of the National Fellow Online Lecture Series, which are to serve as an adjunct to your individual program's educational content, to provide fellows with direct access to educational experiences with AMSSM members, and at times invited guest experts in a variety of different formats, and lastly, and probably most importantly, to assist in CAQ exam preparation. Now we're recording this ahead of time, so a lot of these last reminders don't particularly apply. We've prepped some a Q&A session at the end and also have included a CAQ practice question as well. So please tune in, and now without further ado, welcome Dr. Borowski.
Thank you, Dr. Wise, for having me. I'm really happy to be able to be here with you tonight. I know we're recording this ahead of time, but very happy to be invited to speak with you guys. So I'm going to go ahead and share my screen now. Okay. So tonight I have been asked to speak about some rheumatologic considerations that we see in the sports medicine clinic. And I have no conflicts of interest, no disclosures. My objectives are quite simple. I'm going to review a couple of rheumatologic diagnoses that you are going to encounter in the sports medicine clinic, and to discuss the workup that I do prior to a referral to my rheumatology colleagues. So I decided to do this case-based. I think that's a good way to approach it. And these are certainly patients that I have seen in my clinic. It's either a very specific patient or a compilation of patients that I've seen. So the first case is a 27-year-old man with chronic low back pain, and he reports a 3-year history of this back pain. His pain, when you ask him further questions, it's worse in the morning. It does get better as he moves around. Now, in the state of New York, we have a direct access to physical therapy. So even though he hasn't really seen a physician for his issue, he has been trying physical therapy in the past. So what that means by direct access is that you can actually go see a physical therapist for 10 visits or 30 days, whichever one comes sooner. And some states have this available to them. New York is certainly one of them. He's tried some over-the-counter anti-inflammatories like ibuprofen and Aleve, as well as acupuncture, which I think acupuncture is definitely one of my go-tos for chronic back pain. So I was happy to hear that he tried that as an adjunct to his therapy and some anti-inflammatories. But like I mentioned, he hadn't yet been seen by a physician, so had not really had any sort of imaging to date, even though he's had it been going on for 3 years. So when I saw him on physical exam, he had some tenderness palpation of the bilateral posterior superior iliac spine areas. He had good range of motion with flexion, extension, rotation, and side bending bilaterally, but he did have some pain with extension. He did have a positive Faber. So in this case, he was positive for pain in the posterior aspect of the hip, so in the low back area. So you can have a positive Faber with either pain anteriorly, which is indicative more of an intra-articular hip pathology, like a hip impingement, or you can have it be positive for pain in the back. So it's really whichever one. I consider it positive if it recreates that person's pain. And so this one was pain in the low back area. He had a negative FADIR, so negative for interarticular signs there, a negative Gainsland's SI compression and distraction, which are also the Gainsland's compression and distraction are all for SI joint pathology. He also had 5 out of 5 strength in his lower extremities. So at this point, I started thinking about a differential, and really actually before I go into my office, into the exam room, I started thinking about, okay, they're this old and they have this problem going on. What are the things that could possibly be causing this person's pain? So the first thing would be mechanical back pain. Do they just have, pain that has been going on for several years because of, their biomechanics? Spondyloarthropathy is actually very, very much on the top of my list for a young person that's had pain going on for this long. Spondylolysis, which I see quite a bit of because I treat a population that does a lot of repeated extension. So I see quite a few dancers in my clinic. I have a special clinic just for dance medicine, 1/2 day a week. And so spondylolysis is something that I see quite a bit of, or at least have it very high on my differential. Discogenic pain, so either a fissure of an annular fissure or an actual frank herniated disc can certainly be causing this person's pain that he just has recurrent flares of. And then SI joint dysfunction, which I think can sometimes be a little bit nebulous because it doesn't really show up all that often with issues actually on radiographs. So speaking of radiographs, in this person, he's been having pain for 3 years. I would want to start with some sort of imaging. So he was having pain kind of in his low back as well as tenderness palpation over his SI joint. So I start with a SI joint X-ray, a sacrum X-ray. What I'm looking for, and I also get lumbar X-rays as well. And what I'm looking for are anatomical variants. Do they have some sort of transitional anatomy? Do they have, large transverse process that's possibly causing some pseudo articulation? Do they have any sort of signs that would lead me to think they've got more of a congenital stenosis issue? And then also looking for that SI joint sclerosis. Do they have issues or signs that already are pointing to erosions and in the area of the SI joints? With lumbar X-rays, now this is not this particular patient's X-ray because it is much more of a later sign, but what you're looking for would be in a spondyloarthropathy case would be something like this, where you start to have squaring off of the vertebrae, where you start to have new bone formation kind of in the front interior portion of the vertebra, and then the late stage findings of actual fusion of the facet joints and the vertebrae come much later. So it's unlikely to see this bamboo spine in the clinic very often, but it is something that we get taught about in medical school all the time. So this is why I wanted to talk about this, because that bamboo sign, that bamboo spine is not something you're going to see very commonly. So you want to look for other things that might be pointing you down that spondyloarthropathy pathway. In him, if I'm thinking some sort of sacroiliitis because of the tenderness to that tenderness palpation, that posterior superior iliac spine, on this X-ray, it looks like there could be a little bit of signs of sclerosis along those SI joints. It's hard to say, but something I'm highly suspicious of. I would start to get labs, and the labs I'd be looking for are inflammatory markers like an ESR and a CRP. I usually get a CBC and a CMP to look for other signs of systemic problems like a white blood cell count that's either too high or too low, metabolic problems. And then when we're thinking about spondyloarthropathies, which is what ankylosing spondylitis is considered, I do get an HLA-B27. So there is a correlation between those with ankylosing spondylitis and HLA-B27. However, of those that are HLA-B27 positive, only 5 to 6% of those actually have ankylosing spondylitis. So there are plenty of people out there that do have a positive HLA-B27 that don't have ankylosing spondylitis. One of the things I usually end up getting, because of the fact that the signs of the bamboo spine comes much later in the disease process of an axial arthropathy like ankylosing spondylitis, if I'm concerned about a sacroiliitis, I will get an MRI because it's that much more sensitive for things like this. So this MRI shows bony edema and erosions of the sacroiliac joint, which you can see both on both sides, more erosions on that left SI joint than the right, but certainly bony edema on both. And so this can be really helpful in trying to figure out, are they in an acute process? Is it actually there? Is the slight sclerosis that you might see on X-ray actually for real? So in this case, our 27-year-old gentleman that came in with 3 years of lower back pain that was worse in the morning and gets better with activity, he eventually did go on to get diagnosed with ankylosing spondylitis. And it's like I was mentioning, ankylosing spondylitis is an axial arthropathy with radiographic evidence, and other spondyloarthropathies include psoriatic arthritis, some reactive arthritis, inflammatory bowel disease associated arthropathy as well. And the prevalence is really is small, so it's 0.9 to 1.4% of the adult population. The diagnosis is very commonly delayed. So people will go on to have these issues for years before someone actually goes to check their labs and looks at this imaging and goes on to refer them to a rheumatologist to make this diagnosis as well. And I think that most of the time it's because of this dramatic phenotype of this spine. This bamboo spine is not seen until later. So what are the other things we need to keep looking for? And if any of you guys were at AMSSM last week and you heard Dr. DeMarie, who was a rheumatologist that spoke about this, she went on to say exactly this. We need to be looking for these other signs that could point us in this axial spondyloarthropathy pathway. So the other things that can commonly be seen with these are enthesitis, so inflammation where the tendons actually insert. So in this picture, you can see with this Achilles tendon, dactylitis, so sausage finger or sausage digit, that you can see the swelling of the whole digit, buttock pain, spinal immobility, and then postural changes. So postural changes kind of happen later in the disease course too, but one of the ones that you'll see is this hyperkyphosis. So in the patient that I saw in this example, he still had good range of motion. Even though he may have already had some subtle sacroiliitis and some spine changes, he still had good range of motion when I saw him. The things to really think about when you're thinking of an inflammatory back pain or inflammatory process underlying this person's long onset or long chronic back pain problem is that you want to think of it when somebody's coming to your office and they've had pain for a long time, greater than 3 months, and they're under 45 years old. It's an insidious onset typically, and they will have morning stiffness, usually greater than 30 minutes. That's kind of the key here with a lot of the rheumatologic inflammatory issues, right? Is that they'll have morning stiffness. They will have improvement with movement and no improvement with rest. Oftentimes these people will be woken up from their sleep with pain, and most of the time it's in the second half of the night because they've been sleeping and sitting still and lying still for hours, and they get this stiffness that does improve as they arise from sleeping. And then importantly, also this alternating buttock pain too. So you can have pain on the right side 1 week and then pain on the left side the next week, and it kind of plays off of each other. And so when you ask them which side hurts more, they'll often tell you it switches off and on. What do we do for treatment? It's really about pain relief and maintaining as much spinal motion as we can. The spine was meant to move. And so we're trying to prevent these complications by continuing to have them be active. So physical therapy, regular exercise, postural training. So certainly we don't want to exacerbate the spinal problems that are happening by having, poor muscular endurance of the paraspinal muscles. So working on that postural training as much as we can. Medications like an anti-inflammatory. Myself and a lot of our rheumatologists at NYU will do like a meloxicam because it is once a day. So it's an easy medication to take so they can tolerate it and they have a good response. It's a good one to try. And then if that's not enough, then we certainly start thinking about things like TNF inhibitors or tumor necrosis factor inhibitors. And some of the recommendations from the American College of Rheumatology will talk about how oral steroids are not recommended. And Part of that is because it is an ongoing long-term problem. And so being on long-term oral steroids is not necessarily the best thing for someone's overall health for many reasons. So going on to case 2. So case 2 is a 68-year-old man with a swollen right knee. And he showed up in my office, pain and swelling just started 2 days prior to when he saw me, and he was having a lot of pain. He didn't have any specific injury, just kind of started out of nowhere. His pain worsens with any time he would go through the range of motion of the knee. He'd used some Tylenol, but it hadn't been very effective, really stuck to Tylenol because he had other comorbidities with some GERD and coronary artery disease. So he tries not to take any anti-inflammatories. On his physical exam, he had a large effusion. His range of motion, he had good extension. He was able to get to 0, but really not able to get past 90 degrees. And then he had tenderness palpation over both medial and lateral joint lines. Negative McMurray, valgus, and various stress testing, and then negative Lockman. So again, even before I go into the room, I start thinking like a 68-year-old man with left knee pain, right? So the first thing on my differential is osteoarthritis, which is, probably by far and away the most common thing that you're going to see in this age group. But then in addition, you'll also see degenerative meniscus tears. You could have an acute meniscus tear, an acute on chronic meniscus issue. He did not have a history of gout, but he certainly is in the age group that could have it, as well as pseudogout, and then infection. So taking a good history to find out, does he have a prosthetic? Does he have any sort of hardware anywhere else? Did he have a recent infection in some other part of the body that could have, hematologically spread and seeded this joint? So a good history taking is very important. So for this gentleman, we got x-rays, and the x-rays showed just some mild arthritis. And then, you can see that by some mild narrowing of the joint line on that medial joint line with the tiniest little osteophyte there marginally. And then if you look laterally, which I'm going to zoom in here in just a second, you will see that there's this haziness in the area of the lateral meniscus. And so I chose this case in particular because it's subtle, right? It's really, really subtle to see these things sometimes. Sometimes it's a lot more obvious where you can have, significant calcium stippling this joint line, but this is subtle. And so sometimes it may not be as obvious to you that there is some chondrocalcinosis in that lateral meniscus area. So I did an aspiration, and I sent for fluid analysis, and the culture didn't grow anything after 5 days, but it did. And the cell count, which I don't have listed here, but it was more of an inflammatory process with less than 50,000 on it. So the thing of note was the calcium pyrophosphate dihydrate crystals that were present. So this gentleman was diagnosed with pseudogout. And so pseudogout is sometimes also called calcium pyrophosphate dihydrate deposition disease, so CPPD. And it's clinically, when you see it in the office, is very similar to gout. The episodes, like gout, are characterized by this acute onset of pretty severe pain without an inciting injury. Sometimes it can be precipitated by an infection. Sometimes it can be precipitated by an injury, but usually not. Or usually it's unknown to the patient what precipitated it, but they will have redness, swelling, and warmth. The pain can be very intense. And with pseudogout, it actually can take longer to get to the peak of intensity in pain than gout, and it may last longer than 3 months, even though you've treated it. The knee is most commonly involved, but you can also see it like gout, you can also see it in other joints. With pseudogout, you then most commonly see it after the knee in the wrist, ankle, elbow, toe, shoulder, hip. It's largely a disease of older people, so people in the later stages of life that you would commonly see osteoarthritis in, or degenerative meniscus tears. So this can really be a tricky picture sometimes to discern which of these things is actually causing my patient's pain at this time. We're probably seeing a lot more chondrocalcinosis and a lot more pseudogout, and not necessarily calling it that. So how do we diagnose it? So again, clinical history. You'll see this chondrocalcinosis on x-ray, and then you'll also see the calcium pyrophosphate crystals. dihydrate crystals on the fluid analysis. So those three things can kind of help you put this clinical picture together. And how do we treat it? So NSAIDs can be very helpful. So an anti-inflammatory, you can use something like an indomethacin. I usually use something like a diclofenac or a meloxicam at first to see if that's helpful. You can do an intra-articular steroid. It can be from a monoarticular, possibly 2 joints. And then oral steroids if it seems to be more of a wider spread, more polyarticular issue. Colchicine can be effective in an acute flare, but in terms of the long-term medications that we use for gout, they're not effective right now against CPPD. So we don't use things like febuxostat and allopurinol for pseudogout. So now I'm going to we're going to get into a couple of questions. I've kind of sprinkled them throughout the lecture a little bit. So this is a 55-year-old male golfer who presents with isolated right shoulder pain, swelling, erythema, and warmth. There were no traumatic precipitating events. Radiographs demonstrate chondrocalcinosis, and needle aspiration of the joint yields synovial fluid with crystals. These crystals would also demonstrate which of the following characteristics: consist of calcium pyrophosphate, exhibit negative birefringence, are needle-shaped, or consist of monosodium urate. So if you were listening at all to the last couple of slides, you would know that with chondrocalcinosis and you're thinking pseudogout, it's going to be the calcium pyrophosphate. So let's go through this summary of the answer a little bit though. So, because it pulls out some good points. And I've kind of highlighted a couple of them here. So the presence of chondrocalcinosis with crystals in the synovial fluid aspirate indicates pseudogout. Crystals in pseudogout are calcium pyrophosphate. Under polarizing light, pseudogout crystals are blue. So this, I'm going to skip a little bit here, and blue with a pseudogout crystal shows positive birefringence, whereas monosodium urate crystals in gout have a negative birefringence and are typically yellow. A pseudogout crystal is a rhomboid to rod-shaped with blue ends. Gout crystals, monosodium urate crystals, are needle-shaped and often yellow, and are yellow. Okay, so those are the key things to take away from that for the CIQ. All right, moving on. So case 3, this one is a little tricky, and I put it in here because of that, because there's a couple of things to highlight with this case. So 13-year-old girl with a swollen right knee. Okay, she comes to you. This is a patient that I've had for several years. I've seen her for a number of other things. She's, not always hurt, but does get a lot of things, and that have her ending up in my office. She plays soccer regularly, and she started having, oh, I'm sorry, mix up the sides here. It was right knee pain. That should say right knee pain and swelling about a week ago. Hurts with all movements, but not particularly painful at rest. So anytime she moves it, it's painful. And she says it's because it's so swollen that it hurts. And she denies any specific injury. So even though she's playing soccer, she doesn't really remember any specific moment in a soccer game where she had an injury. On physical exam, she's afebrile. She has a respiratory rate and heart rate that were within normal limits. And her range of motion of this right knee is only 5 degrees to about 110 degrees. So she really can't get full extension, and she definitely doesn't get full flexion, because her other contralateral knee, her left knee, is 0 to 140. So she's got really good flexibility on the other side, but she has this very large effusion. So anytime you're putting her through this range of motion, it's painful, and she can't bend it very far. She does have tenderness palpation over the lateral joint line. She has a negative McMurray and a Thessaly, and no laxity with varus or valgus stress. Now, some of this was also hard to get because she was in a lot of pain just moving the knee at all. So doing a McMurray didn't elicit a painful positive click, but was uncomfortable for her. So what are you thinking when you think of a 13-year-old girl who plays soccer that has knee pain and now an effusion? So my first thought was, does she have some sort of meniscus tear? Does she have a ligamentous injury? Does she have osteochondritis dissecans? Does she have, it's monoarticular, so she only has this one joint that's really swollen. Is it juvenile idiopathic arthritis that could be, presenting in this way? Does she have Lyme disease? So I live in the Northeast. I'm in New York City. And even though you may not think that it's in New York City, they've found deer ticks in Central Park. I actually live in New Jersey and now commute into New York. And I actually had to stop on the street today and let a deer cross in front of my car in order to get to the playground with my children. So in the middle of the day. So they're out there. It's very prevalent in the Northeast and the Midwest. So I wanted to see what more was going on with this young woman. So I got an X-ray, which showed no acute bony abnormality, but she did have this very large effusion. So if you look here, you can see this very large area here, that fat pad and that effusion in the suprapatellar region there. And I also aspirated the knee because with that much fluid, I was thinking, this should probably be something we should send for workup, right? On that list of things, I did put, I would have thought of infection, but she didn't have, this particular case did not have a lot of redness or warmth per se. And so infection was certainly much lower on my list. When I sent her fluid for analysis, it did come back positive for Lyme via PCR. While I was waiting for the Lyme, I ordered an MRI on that same day that I first saw her, and her MRI came back as showing a lateral meniscus tear as well with a discoid meniscus. So this is why I think this case is a little bit tricky, right? So which one's causing her the pain? Is it the Lyme that's acutely causing her this issue? Or does she get this lateral meniscus tear and in the setting of this discoid meniscus, which we know a discoid meniscus can increase your risk of having tears. So this was her MRI. As you can see, she's got a significant effusion with a lot of synovitis. And I think this is the key to knowing which one you should really going to go for first, right? So Lyme arthritis is going to give you a very large effusion most of the time. So you'll have this significant amount. And this would be a large amount for a lateral meniscus tear. In my practice, I haven't seen someone that typically has this large of an effusion with a meniscus injury. But in addition to that effusion, you can see the anterior horn, and I only have one slice here, but it did go into the mid portion of the body of this lateral meniscus. That was the meniscus tear. So, and this is another view of it. You can see here more peripheral tear here. So with Lyme arthritis, which I said is very prevalent in the Northeast and upper Midwest United States. It was first described in 1977 after an outbreak of what seems like juvenile idiopathic arthritis in Lyme, Connecticut. And it wasn't until really 1982 when Dr. Bergdorfer actually isolated that particular spirochete that we know of as Borrelia burgdorferi that causes this Lyme arthritis most commonly in the United States. It is the most common vector-borne illness in North America and Europe. And the vector is most commonly the Ixodes tick, which is a black-legged deer tick, which you can see here. The CDC has this nice depiction of on their website. And most of the time, it's the nymph and larva stage that can often get missed. And that's what stages are often the ones that will cause the infection. And it happens to be that the tick has to be attached for about 72 hours for there to really be a transfer of the organism. So, as soon as you find a tick, take it off. It has to do with the fact that things get kind of mixed in the midgut of the tick, and it takes a while for that transference of the actual bacteria. And so, if you see it, take it off. It's not a problem to go and get a one-time dose prophylactically of a doxycycline, or if they're younger, doing like an amoxicillin. But even if you have it on for about 72 hours, only about 25% of those people will end up having some sort of Lyme disease too. So don't freak out, but go see somebody if you find the tick. Before antibiotics, up to 60% of people were actually developing Lyme arthritis after they developed Lyme, but after antibiotics, it's been much lower than that, because Lyme arthritis is a late stage manifestation. So it can occur 4 days to 2 years after somebody finds that bullseye rash, that erythema migrans rash. And in some cases, the Lyme arthritis is actually the first presentation of the disease in general. And like I was mentioning earlier, they tend to have these very large effusions on exam. So I wanted to go over a couple of these guidelines because I think, I went to medical school in Philadelphia. And so being again in the Northeast, it was something that was like, put Lyme under differential. Like Lyme was on the differential for almost everything, whether it be encephalitis or arthritis. And so these are practical guidelines that were put out in 2021 by the Infectious Disease Society of America, as well as the American Academy of Neurology and the American College of Rheumatology. And so it touches base on all of those things, all the different body systems that are affected by Lyme. And so I just picked out the ones particularly with Lyme arthritis. So they recommend that we do serum antibody testing over PCR or culture of blood or synovial fluid. And this was a strong recommendation. And if you are thinking that if you have a seropositive patient who you think has Lyme arthritis and you're considering treating them, which I would, they also recommended PCR from the synovial fluid if you can get it, as opposed to a Borrelia culture. So you want to do PCR whenever you can. In my practice, I will get, if I can aspirate a joint, because I think the effusion is coming from an arthritis or a Lyme arthritis, I will send for PCR. But there are quite a few patients in my population that the arthritis has been there or the joint pain has been there for a while. They may not have much of an effusion. It may be something that they have multiple joints going on that I will test for serology. So that's one of the reasons why I end up getting Lyme titers, is because the picture's just not matching up and no one's ever tested them for Lyme, which is why it's important to test for both the antibodies as then have a reflex for Western blot to confirm it, is the way that it's done. What antibiotics do we actually use? So for patients with Lyme arthritis, we recommend using an oral antibiotic for 28 days. Typically it's a doxycycline. And then what happens if it doesn't completely resolve? So what happens if they take that 28 days? Well, there's not great recommendations as to what we should do next. So you can do a second course of oral, or you can start an IV course of ceftriaxone. And so not great recommendations either way, but in my practice, what I do is I usually do 28 days. I send them to rheumatology to help them co-manage it. If they are not better at 28 days, I will extend it for another 2 weeks. And then at that point, I'm working with my rheumatology colleagues to decide, okay, do we have to start some sort of IV antibiotics? And then what if they failed antibiotics? If they failed oral antibiotics and a course of IV antibiotics? Well, that's when we start thinking about, okay, do we need to start adding in something like a DMARD, so a disease-modifying anti-rheumatic drug, some sort of biologic agent? You can do a synovectomy if it's really prolonged and they're refractory to antibiotics. But there has been not a lot of great evidence for these recommendations. But we all kind of agree that antibiotic therapy beyond 8 weeks really isn't going to give you additional benefits. So we don't want to completely destroy your gut for much longer than we need to with an antibiotic. So coming up with these other things to try and help resolve some of these symptoms might be helpful. And now the last case. So case 4, 70-year-old woman comes to you just complaining about having difficulty getting out of a chair. And I made this one purposely vague because this is what you'll see sometimes. Sometimes people will just come to your clinic and they're like, can't walk anymore. Like, I have trouble walking. I'm not as fast as I used to be. I can't get out of a chair. It's hard for me to get out of bed. So this woman in particular had symptoms that had only really been going on for about 2 weeks. The stiffness was worse again in the morning. She feels better when she gets up and moving around. And her other symptoms were vague. So she had malaise. She was fatigued. She really didn't have any fevers, but she did have pain and difficulty with moving the shoulders in particular. She was up to date on her cancer screening, so really wasn't dealing with any sort of underlying malignancy that we had known of. And the reason I mentioned that will come up in a second when we talk about the differential. So on her physical exam, she had difficulty getting out of the chair with using both hands, and certainly was unable to get out of a chair without using either hand. And so that timed up and go test was pretty abysmal. She wasn't able to get out without using her hands. Her range of motion in the shoulders, it wasn't bad once she got it moving. So forward flexion at 160, it looked pretty, okay. Abduction to 170, internal rotation to about T10, and external rotation to about 50 bilaterally. She had pain though with all of the movements of the shoulders. And when I start thinking about this differential, it's very broad. Could she have adhesive capsulitis of her shoulders? Sure, but does that necessarily explain her hips? She could have adhesive capsulitis of the hips, which I've seen, but it's very rare. It's not common. Hypothyroidism, so having this just like sluggish malaise, fatigue issue. Does she have fibromyalgia? We certainly all see a lot of fibromyalgia patients in our office. Does she have depression? Depression can present in a lot of different ways, and having, slowed motor skills can certainly be one way that depression presents itself. Parkinson's disease, so having again that slowed gait, and that can be a Parkinsonian type feature. Does she have a perineoplastic syndrome? And that's what I meant when I was alluding to having being up to date in all of our cancer screenings, right? Does she have other things that are underlying? Is this a multiple myeloma type picture where has this metabolic storm and metabolic things that are going on underlying her issues? So I bring this up to talk about polymyalgia rheumatica, which is more common in women than in men, and it usually occurs between the ages of 50 and 80. This is something that you will see. I know certainly from my family medicine colleagues, you'll see it. I certainly saw it when I was, we had to do our nursing home rounds and our nursing home rotations in residency, but you will see it come through your office as well. And it's just something to keep in mind. Maybe it actually has seen more of you than you've seen of it. It is associated with giant cell arteritis in about 10 to 20% of cases. And generally, it starts with this acute onset of shoulder pain and morning stiffness, and it affects the pelvic girdle as well, which is why they have such difficulty getting up and out of a chair. The pathophysiology is really this synovial and periarticular inflammation and this vascular proliferation, which is often mediated by IL-6. And the European League Against Rheumatism and the American College of Rheumatology has this classification criteria for polymyalgia rheumatica. And again, like a lot of other rheumatologic problems, it's morning stiffness, hip pain, or limited range of motion. And then they start talking about some of the labs, so the absence of rheumatoid factor and other labs that we will check for our rheumatology colleagues, the absence of other joint involvement. And then this is one that's interesting too. So at least one shoulder with subdeltoid bursitis or biceps tenosynovitis or glenohumeral synovitis, and or one hip with synovitis or trochanteric bursitis. So you got all these points and you add them up, and some of them require you to use ultrasound, or obviously to see some of that subdeltoid bursitis or the sometimes they're trochanteric bursitis. So you can use this as a kind of way to guide your clinical diagnosis as to whether or not they have polymyalgia rheumatica. And so the diagnosis is clinical based on this criteria and getting some labs like they mentioned, which I'll go over on the next couple of slides as to which ones I get. But the treatment is glucocorticoid. So typically people will get started on prednisolone, 12 to 25 milligrams daily, and their symptoms go away pretty quickly. Within a couple of days, they'll start feeling very well. However, people can be on this for a long time. So it sometimes can take a very long time to taper off of the steroids, and they may notice symptoms get re-exacerbated. It can recur, so they may end up back on steroids too. And then there is some correlation between some cancers, between cancers and this picture. So that's why it's always good to make sure that they are up to date on their cancer screening. Oh, sorry. So when do I refer to rheumatology? So when the picture is not clear, when the patients have been coming to me for a multitude of different issues, this is something that I start to think about, am I missing something else, right? So do I have a patient with multiple joint complaints, particularly small joints, and they're not responding to the typical treatment? We're trying anti-inflammatories, we're trying physical therapy, we're trying adjunctive therapies like acupuncture, and talking about healthy lifestyles. younger to middle-aged patients with multiple enthesitis or tendonitis issues. So this is something that I have brought into my practice over the last couple of years to be like, okay, well, now you've got tennis elbow and you had, Achilles tendon issues before, and you're only 35 and you seem to have some glute tendinopathy too. So it's something to just put into the back of your mind to think of, okay, maybe there's something underlying here that we're missing. Maybe we need to start thinking about this a little bit more frequently. And those with autoimmune and inflammatory issues that are now coming to me with a joint presentation. So people who have psoriasis, or those people who have some sort of inflammatory bowel disease, whether it be Crohn's or ulcerative colitis, and now they have a significant joint effusion or significant, limited range of motion in a joint. So those are things that I start to think about and will send to my rheumatology colleagues just to say, hey, is this an articular manifestation of their underlying process, and kind of co-manage with them. And when it comes to labs that I order, these are ones that actually our rheumatology department here at NYU really likes to see prior to us sending to them. And so this is by no means an extensive list of the labs that rheumatology orders, but this is the basic ones that we will start with. So I always start with a CBC and a CMP to make sure that we're not, to look at those underlying metabolic issues, or, anemia, white blood cell count. I will always get an ESR and a CRP to look for those inflammatory markers, and the higher they may be, they could indicate a more widespread systemic problem. A rheumatoid factor, an anti-CCP. I do get an ANA, although I know that many people will have a positive ANA, and up to about 10% of the normal population will have a positive ANA and have no other symptoms. So I am, aware of that, but it is something that our rheumatology colleagues here at least like to see. And then the HLA-B27, I don't routinely order HLA-B27. Again, it's only if I see somebody that I'm thinking has a sacroiliitis or a possible axial spondyloarthropathy. I will get a vitamin D. Again, we live in the Northeast, so we're always covered up, and sometimes very low vitamin D can cause a lot of discomfort and fatigue and bone pain in some people. So if you can replace that, sometimes people will have some resolution of their symptoms. And then, like I mentioned, the Lyme titers with that reflex Western blot. Couple other questions here. So which of the following describes the characteristic distributions of joints affected by rheumatoid arthritis? Asymmetric involvement of the large joints, involvement primarily of weight-bearing joints, symmetric involvement of large joints, or the symmetric involvement of small joints. I know I didn't cover rheumatoid arthritis in this talk, but I think this is something that we should all know, and certainly will be asked on the CAQ. So it's the symmetric involvement of the small joints. And here's the rationale behind it. So it presents with pain in multiple joints that is usually symmetric. Pain and synovitis involving small joints such as the hands, wrists, or feet. Osteoarthritis is more commonly monoarticular or asymmetric, and often involves weight-bearing joints like the hips or the knees. When osteoarthritis involves the hands, it tends to involve the DIPs, while rheumatoid arthritis tends to involve the MCPs and PIPs. And there are some of my references. And thank you, guys. Appreciate you having me.
Awesome. Well, thank you for that great talk, Dr. Borowski. I think this topic
sharing here.
There we go. Relevant as well as relevant in practice, given the overlap in MSK medicine. So thank you. Couple questions, couple follow-up questions for you. So in ankylosing spondylitis, given that fusion and bamboo spine, like you mentioned, are typically late stage features, do you typically get MRIs, or maybe how common are you getting MRIs in patients in which you suspect like an inflammatory cause of their back pain?
Yeah, I think that if I am highly suspicious of a sacral, like certainly if I see some sort of signs of sclerosis or erosions on my x-ray, I get it right away. If I don't, but I'm still suspicious of it, I will get those labs that I mentioned, like the ESR and the CRP, and the HLA-B27. I will often have them go through a course of physical therapy and try a different anti-inflammatory, and see if just changing up, physical therapy providers or changing up the anti-inflammatory will be enough to help them with their relief. And then I'll send them back for a follow-up. If it hasn't changed a whole lot, then I get the MRI. I think it's important to not let them linger longer, because we want to make that diagnosis, right? The other thing that I find tricky about rheumatologic issues is often that they may not be, you may not see it right away, right? So there are things that actually can still develop too, right? So like patients may have, these things that may not add up to you right away. Like they have, some wrist pain, they've got some finger joint pain, and they may show up a year later with knee pain. And they're like, man, let me check their labs, let me see if it's something. And they're completely normal. And then, 5 years from now, you may check them again and something starts brewing, right? Like something's been brewing and now the labs are maybe a little bit more positive. So I just having an under differential and then pulling the trigger with that MRI of the MRI of the sacrum, I think is not unreasonable.
That makes a lot of sense. I'm really glad that you brought up Pseudogout. I've actually seen that a couple times already in the past year, one of which was in ski clinic. So that was an interesting conversation. But I want to ask, how definitive is chondrocalcinosis for Pseudogout? The reason I ask this is because if you see this on films for a patient who's presenting with a knee effusion, do you still need to do like the full workup, for example, like including for septic arthritis and that type of thing?
I think the septic arthritis certainly is something that you definitely should work up if you have a high clinical suspicion for it. Like if they have, certainly if they have some sort of history of like a recent surgery or recent infection elsewhere, keeping that in mind, it's going to be extremely painful for them to move that septic joint. I can't say that I do that workup every single time, but I will aspirate them and I'll send it, I don't necessarily start antibiotics, right? So I do aspirate it every time that I can and send it for fluid analysis. That being said, there are some studies that show up to 50% of people by the time they're in their 80s will have some sort of chondrocalcinosis on X-ray, right? And so it's a high percentage of people that will have some sort of calcium deposition in the, hyaline and fibrocartilage of the joint. And so that's why I think it's hard to differentiate sometimes, right? So that's why sending that fluid is important. Seeing those crystals can kind of make it maybe a little bit more clear for that period of time, because the people that we're seeing Pseudogout in those people that have degenerative arthritis as well as degenerative meniscus tear. So like any of those things can be causing their acute pain. But I think that, keeping it in mind and knowing that chondrocalcinosis is really prevalent. So that's why maybe going towards the fluid analysis is a better option for diagnosis.
I see what you mean. I was not expecting the Lyme arthritis, to be honest, but I think it's super relevant from where you practice. And I think Lyme is also in other places. Like I saw it a couple times in residency in Seattle and certainly actually a fair bit in Texas as well.
Mm-hmm.
I think it's interesting that the IDSA recommends the antibody testing and before the synovial fluid analysis. So I appreciate that you brought that up. If you're getting positive PCRs on synovial fluid analysis, to me that may imply that there's some infection in the joint. Is like a joint washout ever involved, or can you just confidently say, hey, we'll get them 28 days of doxycycline or amoxicillin in the pediatric population and see how that does? Should we be thinking about this more as an inflammatory condition than like a truly septic joint?
Yeah, it's a really good question, right? Because you're like, well, if the PCR is there, then obviously there's some sort of, if that PCR is positive, then there's bacteria there, right? Or so we think. But it really sets off a really strong inflammatory cascade. And so when you look at the joint fluid of people with a Lyme arthritis, it often is more of an inflammatory picture than an infectious picture. So they'll kind of hovering in between like 25 to 25, 30 to 50 of that white blood cell. So it's often a little bit more of an inflammatory type picture when you're looking at the fluid, even though you do have that positive PCR, and it generally responds really well to antibiotics. And so I think that's why you see them say, let's go the antibiotic route for 28 days and avoid that washout if we can. Because most people will respond to the actual antibiotic, and you want to kill the whole process, right? Like you have to kill it systemically as well. And so I think that's why we see it, because it does usually respond. But for those that don't, those people do end up going on to get perhaps like a synovectomy, because the inflammatory response has been so great at that point.
Okay. Okay, well, that's super helpful.
Mhm.
Last question for you, has to do with PMR. I appreciate you bringing up the diagnostic criteria, and it made me wonder how many trochanteric bursitis patients actually had underlying PMR that I haven't diagnosed. But I guess kind of last question would be, do you have a sense of why those, what would you say, bursities are part of the diagnosis? Do you think it's like secondary to the weakness in the muscles from the PMR, maybe loading those tendons? Just want to kind of get your 2 cents.
Yeah, I mean, it's a good question. I mean, so the, the pathogenesis of it being more of like a synovial and periarticular inflammation, I think probably has a lot to do with it, along with the neovascularization. So you're just bringing a lot more to that area. And it certainly could, compound the problem where these patients are feeling weak and then these tendons are not getting, worked in the way that they should. And so they end up getting weaker, causing more bursitis in the area. So it's kind of, I think it's a little bit of a compounding issue. But why exactly we see the bursitis, I'm not 100% sure. Yeah.
Great. Well, again, thank you for an amazing talk. Thank you for everyone for tuning in, and we'll see you next week.
Thank you guys. Appreciate it.